Hi, Dr. Ahrenholz.
Good morning.
My name is Wendy. Good morning.
Yeah.
I'm Wendy Dahl. I'm one of the nurse practitioners up here at St. Elsewhere Hospital. And I have a gentleman that was brought in by his buddies this morning, and he's got a frozen right arm. And I'm not sure what I should be doing with this arm.
Okay, well, do we have any reason why he might have been out? Do you think he was assaulted or maybe he's intoxicated?
I didn't get a great history, so if you give me just a minute, I'll go get a good history and call you right back.
Okay, and check a core temperature for me too, please.
Okay. Okay, Dr. Ahrenholz, I'm back. I've got a little more history. This gentleman was out partying with his buddies last night and left the party and evidently must have passed out outside. His buddies found him this morning and brought him in. His vital signs are 110/60. His heart rate is 50. His respiratory rate is 12. His SAT is 96% on the left hand. I started an IV with saline at TKO, and I sent off labs for a U-tox, a serum tox, and electrolytes.
Great. And what's his core temp?
His core temp is 30 degrees Celsius by tympanic.
Okay. So it sounds like he's hypothermic, and that goes along with that bradycardia as well. So we don't want to rewarm the arm until we've made sure that we've raised his core temperature.
Do you have the capability of measuring his core temperature with a Foley tipped with a thermistor so that we can get a real-time reading?
Yes, I do believe that we've got a thermistor Foley here at the hospital.
Okay, that's going to be a real help.
Because what we want to do is we want to see what kind of urine volume he's making, but we also want to make sure that we can monitor his core temperature in real time, and that's going to be the most accurate way to do that.
Okay, great. I'll get started on that, and I'll call you right back.
Okay.
Okay, Dr. Ahrenholz, we did have a thermistor Foley. His core temp is 31.4 core, and he's got 600 mils of urine that came out immediately, but he's making really good urine because as I stand here, I can actually see urine coming down the tube.
So based on that, normally we would expect the patient to be euvolemic, but what we know is that patients who've been outside for a long time actually will continue to make urine despite being hypovolemic, and they get hypovolemic because when they're cold they can no longer concentrate their urine, so they make an ultrafiltrate that just goes right through to the kidneys. So I would plan to give him at least a liter or two of fluid empirically.
All right. Normal saline?
I think that's fine.
Okay. Alrighty. What do you think about central line? If I'm trying to kind of regulate his CVP, should I place a central line?
And that would be our first choice to monitor the volume status in a trauma patient. But what we've learned is that in patients who are hypothermic, if the guide wire touches the myocardium when placing an IJ or a subclavian line, there's a risk of ventricular fibrillation, which is almost impossible to correct in the hypothermic patient.
Just don't respond to cardioversion. So I think we'll reserve that for now. We're going to have to just monitor his vital signs, particularly his blood pressure and his heart rate. And as we warm him up and he vasodilates, he may drop his pressure rather rapidly. But I think giving him extra fluids is going to be the first intervention.
The nurse just came in and said that his heart rate is now dropping down to 40. Do you think I should start some pressors?
Unfortunately, pressors don't work very well in patients who are hypothermic, but it's certainly a great idea. I probably would just give them extra fluid first, and if he responds promptly to that, then I would reserve the pressors for now. But that's the backup plan.
Okay, sounds good.
The other thing is we need to rewarm the patient because he is hypothermic and because he's bradycardic. Have you had the opportunity to rewarm a patient in the past?
No, all I've done is warm blankets and bear huggers and some warm fluid.
Okay, so the first thing we do is we undress the patient and we dry their skin completely, because anything that evaporates from their skin is going to carry away additional heat and drop his temperature further. Once he's dry, we can use either warm blankets or a bear hugger. Those are perfectly fine. What works best, and which is the most rapid way of rewarming a patient, is to immerse them in warm water, either in a Hubbard tank or a bathtub. Do you have that capability?
Yes, we don't have a Hubbard tank, but we do have a bathtub.
So if you can draw bath water at about 40 degrees centigrade and you can immerse him into that water, I think you'll be able to watch his core temperature rise in real time using that thermistor tipped Foley. But be aware, you're going to want to be checking his vital signs fairly frequently and probably giving him extra fluid.
The final thing is that these patients all have really remarkable pain when they're rewarmed. That cold skin, when it's rewarmed, is stimulated and it feels like the skin's on fire. So be prepared to give him IV narcotics, and I don't care if you use fentanyl or Dilaudid or morphine, but make sure it's small doses just to keep his pain under control so he doesn't take a swing at somebody.
Okay, and then what do I do with the arm when I put him in the tub? Do you want me to wrap that in anything, or?
Typically we don't rewarm it immediately, because if we rewarm it first before raising the core temperature, there's a real risk that his core temperature will drop much lower and he may even arrest, and we've seen that in other patients.
So we want to get his core temperature up between 34 and 35 degrees centigrade, and they're going to immerse that arm, and be prepared, it's going to hurt him quite a lot. So you're going to have to give him his narcotics, and then we'll immerse his arm, and I think what you'll see is that his core temperature will again drop.
But hopefully not too low. And then as the arm thaws out, you'll see his core temperature start to rise again as we add that heat from the bathtub.
Okay, great. I'm going to get him in a tub and then I'll call you back.
Great, I'm looking forward to it.
Thanks. Okay, Dr. Ahrenholz, I'm back. We were able to get Mr. Smith warmed up here and get a better history. We thawed his hand and his arm, but now he's got some blisters and his fingers are looking rather gray. I'm very concerned that we might lose those fingers.
I share that concern. What we find in frostbite patients is that after they thaw, sometimes the hand looks very bright and pink temporarily, but then blisters start to form.
And a real worrisome thing is either gray fingers or blisters that form proximally and not distally, because that indicates more perfusion distally. This sounds like a patient who might be a candidate for angiogram and possibly even intraarterial thrombolytics. So we would expect that he might be a patient you would consider for transfer to our burn center.
That sounds great. I'll get the transport started and get him down. It'll take us probably a couple hours to get him to you. Do you think ground transport or air transport?
I would prefer air transport in this case. I think if we can, since he has these poor prognostic signs, if we can do the thrombolytics early, we might expect a better outcome for him.
Great. Thank you very much, Dr. Ahrenholz.
Okay, we'll make him a direct admit.
Okay, thanks.
Bye.